For this week's vlog, I will be addressing an ethical issue related to death and dying. Critical care is known to be devoted to saving lives. The ICU, otherwise known as the intensive care unit, embodies the victories of medical technology in preventing or delaying death, but also shares claims that sometimes technology goes too far. The main topic of discussion will be the ethical dilemma of the death and dying processes in the pediatric intensive care unit. Autonomy is an essential code in medical ethics. It implies that a competent person has a nearly absolute right to decide what shall be done to his or her body. Courts have consistently upheld the right of competent patients to refuse life-saving treatment, even if it appears foolish or unwise to others. Some people may have religious reasons, or some people may not have a reason at all. But regardless of the decision, it belongs in the hands of the patient. Not all, but many adolescent patients meet the standard of being competent enough to decide what shall be done to his or her body. The most common definition relies on the ability of the patient to understand the consequences of his or her decisions. Practices came under criticism in the 1970s and 80s upon disclosure of many cases in which handicapped and critically ill infants who appeared to have good chances for long lives were allowed to die. The dilemma is not about whether medically beneficial treatment can be withheld. The challenge is to define acceptable principles that can help identify those patients who should no longer be treated and determine who should die. I believe this issue I believe this issue incorporates deontology by focusing on the consequences of the patient's and or caretaker's actions, and also shows the importance of operating according to responsibilities and obligations. As crazy it may seem, in some instances, emphasis infants with Down syndrome and other illnesses were allowed to die of dehydration. Not only that, but many infants with spina bifida were withheld standard treatment with the intention of death. There is a compromise in ethics and law that there is no meaningful distinction between withholding and withdrawing life-sustaining treatment. Withdrawing treatment was desirable to withholding for two reasons. One, withdrawing treatment implies that there has been more times for assessment of diagnosis and the likelihood of a successful outcome. Good ethics start with good facts. Second, to withdraw treatment often leads to inappropriate withholding of support from patients who may have had a good chance for a long-term survival. However, there comes a point in life when continued existence does not serve the interests of the patient, and this is usually because the burdens outweighs the benefits. This point is most clear when the patient has no apparent interest. An example being a patient who is incapable of experiencing any of the pleasures of existence or in everlasting comas. There is a major dilemma that occurs from the decision of delaying the death of a patient or letting them die. On one hand, what if a patient who lives would have been better off if they were to die earlier versus a patient who dies who probably would have enjoyed living life? In the intensive care setting, prolonged survivors who are better off dead usually are dependent on some type of technology, and keeping someone alive is reversible, whereas letting someone die is not. I believe life is valued highly, and some people would prefer a handicapped life or existence with some type of suffering over just dying. Time is one thing in life that we can never get back. Timing is critical in the medical industry, and if the opportunity to save someone's life is not conducted in appropriate time, then there is no decision to even be made. If the decision is made of allowing for the death of a patient, there are two processes in which patients utilize, which are active euthanasia and passive euthanasia. Active euthanasia can be defined as a physical act that causes the death of a patient and was intended to be in the patient's interest. Passive euthanasia is generally understood to include withholding or withdrawing treatment with the intent and expectation that death will occur sooner than later. Um, I believe that um, doctors and caretakers must think critically about the implementation of effective communication concerning patients. Hospitals, they have programs and they should be expanding in order to meet the physical and emotional needs of patients with serious or terminal illnesses. Over the past decade, there have been growing awareness of the conflicts between the way Americans say they want to die and how they actually do. But this concludes my presentation.